So today I'll be speaking about an approach to epilepsy surgery in children with Sturge-Weber syndrome. As mentioned, I'm currently at Boston Children's Hospital as an attending in neurology and epilepsy. The objectives of the talk today are to outline the role of epilepsy surgery in the management of children with Sturge-Weber syndrome. I'll discuss the potential benefits and risks of epilepsy surgery in Sturge-Weber syndrome, and we'll review the surgical options in children with Sturge-Weber syndrome. At the end or during the talk, I would be happy to answer your questions. In terms of epilepsy, it is the most common neurological manifestation affecting around 75 to 90% of children with Sturge-Weber syndrome. And it is common for seizures to begin in infancy. There can be a variety of different seizure types. The most common are what we call focal motor seizures. So that can be shaking of one side of the body or stiffening of one side of the body. And focal with impaired awareness seizures are also quite common, and these can be quite subtle, but some of the signs of it include staring, lip movements, purposeless repetitive behavior, and difficulty distracting a child during a seizure. Children with Sturge-Weber syndrome are at risk of prolonged seizures as well as clusters of seizures, and sometimes that may require hospital admission. In terms of how seizures and epilepsy evolve in Sturge-Weber syndrome, it is quite variable. So some children grow out of their seizures, but up to about half of children develop what we call drug-resistant epilepsy. And I'll define what drug-resistant epilepsy is on the next slide. This is a timeline showing a child's journey in epilepsy. So here we have onset of seizures, and that's typically when we begin a child on an anti-seizure medication. If seizures continue despite being on one anti-seizure medication, then a second anti-seizure medication is usually started. If a child continues to have seizures after 2 anti-seizure medications, then that's when we make the diagnosis of drug-resistant epilepsy. And so the formal definition of drug-resistant epilepsy is failure of adequate trials of 2 tolerated and appropriately chosen and used anti-seizure medications to achieve sustained seizure freedom. Once a child is diagnosed with drug-resistant epilepsy, of course, we continue with their medical management, but that's also when we begin considering the possibility of epilepsy surgery. The reason it's important to define and manage drug-resistant epilepsy is because it can have some potential consequences. There can be direct consequences of the seizures themselves. In addition, children with drug-resistant epilepsy are at higher risk of developmental stagnation or regression, neuropsychological comorbidities such as mood issues and anxiety. And in population-wide studies, drug-resistant epilepsy is also associated with decreased quality of life and increased risk of mortality. Now, epilepsy surgery offers a better chance of seizure freedom in children who have been diagnosed with drug-resistant epilepsy. In terms of numbers, after failing 2 anti-seizure medications, the chance of achieving complete seizure freedom with the 3rd, 4th, or subsequent medications is relatively small, about 5 to 10% of people with epilepsy. Attainment of seizure freedom with epilepsy surgery in appropriately selected children with Sturge-Weber syndrome can be as high as 70 to 80%, but of course, it has to be tailored and individualized based on the child's clinical presentation. In terms of what epilepsy surgery entails, it involves identifying and removing the area of the brain that is generating seizures. And it's a very significant decision, and so it's very important to carefully consider the potential risks and weigh it against the potential benefits derived from epilepsy surgery. In terms of potential benefits, the main objective would be seizure freedom or a meaningful reduction in seizures. In some children, potential benefits can also include improvement in their developmental outcomes. In terms of the risks of epilepsy surgery, we typically think of it as risks associated with the surgical procedure and general anesthesia, such as risk of bleeding or infection. And we also think of potential risks to neurological function, including the risk to language development, movement, and vision. As you can imagine, there's many different factors to consider when weighing the risks and benefits of surgery for an individual child. Some of the factors include the severity of their epilepsy. So how long do the seizures last for? How frequent are they occurring? And are the seizures associated with cardiorespiratory distress requiring intervention, hospitalization, or even ICU admission? We also consider if there are any pre-existing neurological deficits. So has the child experienced developmental stagnation or cognitive decline? Do they have pre-existing visual field deficits or a pre-existing hemiparesis, which refers to weakness on one side of the body? And of course, central to this whole discussion and decision is really the family's priorities and preferences. When a child has drug-resistant epilepsy, we may recommend that they pursue the epilepsy surgery workup. And there's two main questions that are identified by this epilepsy surgery workup. The first question to answer is, where are the seizures coming from? And we have different tools for answering this question. The cornerstone is performing an MRI of the brain, and that can help us answer questions such as, which side of the brain is involved? Is the right side of the brain involved, the left side, or both sides? Second, what is the extent of the involvement? Does the Sturge-Weber syndrome affect the whole hemisphere? Does it affect preferentially parts of the hemisphere, or is it restricted to a focal area of the brain? And if serial MRIs are done, then is there progression of the disease in terms of volume loss over time? A second important tool that can help us determine where the seizures are coming from are EEGs, which look at the electrical activity of the brain. If we do capture a seizure on the EEG, then an important question is it coming from the place we expect? Or in other words, is it concordant with what we see on their MRI? There can be other tests that are ordered to answer the question of where seizures are coming from, and these include PET scans, SPECT scans, functional MRIs, and this would be decided on a case-by-case basis whether or not the child needs these additional testing. So that was the first question answered by the epilepsy surgery workup. The second main question to answer is, what are the neurological deficits that may be caused by removing that portion of the brain? And this again there's many complex factors that play into this. There's the surgical factors to consider. So what is the extent of the brain involved? Which side of the brain is involved? And there's also patient factors, including the age of the patient. For example, in young infants and children, their brains are more neuroplastic. And so they may benefit from earlier intervention. Other factors to consider are there already underlying neurological deficits? And so it's very important to do a detailed neurological and ophthalmological examination, and to also do formal neuropsychological testing. Next, I'll talk a little bit about the different patterns of involvement on MRI for children with Sturge-Weber syndrome. And the reason that the pattern of involvement is important is because it helps determine what surgical options might be available for a child. And so the most common pattern of involvement is what we call unilateral hemispheric involvement. This is the classic involvement with Sturge-Weber syndrome, in which one side of the brain, so the entire hemisphere, is affected. In this particular MRI slice, you see that this side of the brain is affected, including there's a brighter signal around this side of the brain, and it's also smaller than the other side of the brain. And so this would be an example where of unilateral hemispheric involvement. A second type of pattern is what we call unilateral heterogeneous involvement. And so with this type of pattern, again, only one side of the brain is involved and all lobes are involved, but certain areas of the brain are more affected than others. So in this particular MRI, at the top here is the front of the brain, on the bottom is the back of the brain, and you can see in terms of the brightness of the MRI findings, you can see that most of the brightness is at the back of the brain, whereas at the front of the brain, there's relatively less brightness and less involvement. And that's quite common in children with Sturge-Weber syndrome, where the front part of the brain is usually relatively spared, and the back part of the brain, which refers to the parietal, occipital, and or temporal lobes, are more affected. And that's because during embryological formation, the areas of that are responsible for forming the facial skin is also closer to the portion of the neural tube that forms the lobes at the back of the brain. And finally, the third MRI pattern of involvement that I'll mention is what we call unilateral focal involvement. And so with this type of involvement, it is confined to only certain lobes of the brain. So in this particular example, you can see that the brightness only affects the back part of this side of the brain, and there's no brightness at the front of this part of the brain. And then in some children, this is a minority of children with Sturge-Weber syndrome, they have what we call bilateral findings. And so that means that the Sturge-Weber syndrome affects both the right and left sides of the brain. Typically, children with bilateral Sturge-Weber syndrome have a more significant neurological presentation. And in this particular example, you see that the right hemisphere, which on MRI is shown on the left side of the page, is affected more so than the left side. And that's evident because the right side of the brain is brighter, as you can see here, whereas there's relatively less brightness on the left side. And so putting all of this together, why are these patterns of involvement so important to distinguish? And that's because it helps determine what the most appropriate surgical option might be. So if a child has unilateral hemispheric involvement, which was the first pattern we looked at, that classic pattern, then usually what's recommended is a hemispherectomy. If they have unilateral focal involvement, where only one area of the brain is involved, then perhaps a focal resection or disconnection would be more appropriate. If they have that second pattern of unilateral heterogeneous involvement, then depending on the case, a hemispherectomy might be offered, whereas in other children with unilateral heterogeneous involvement, a focal resection or disconnection may be more appropriate. I will mention that in children with bilateral involvement, often they're not considered surgical candidates because seizures may be generated from both sides of the brain. However, there are certain scenarios when surgery may be offered. So for example, in a child with bilateral involvement, they might have asymmetric involvement in where the seizures are solely or predominantly coming from one side of the brain. And so in that particular instance, if they do have severe epilepsy, surgery of that more involved side of the brain may still provide partial relief of their seizures. I'll now talk a little bit more about hemispherectomies. This is one of the most effective surgeries, and it's also the most extensive. It's also been performed for many decades. The first anatomical hemispherectomy was performed in the 1920s, and it includes the removal of the entire affected hemisphere. Now, with anatomical hemispherectomies, the complication rate can be relatively high. It is a major surgery, and so issues could include blood loss, as well as a buildup of pressure inside the brain. And this prompted modifications in surgical techniques. And so anatomical hemispherectomy is not used in many centers anymore, except in specific and exceptional cases. They've largely been replaced by functional hemispherotomy. And so in functional hemispherotomy, it involves a complete disconnection of the affected hemisphere from the healthy hemisphere. But in functional hemispherotomy, the difference is that a significant portion of the brain tissue still remains in place. And with functional hemispherotomy, they have a lower complication rate than the previous anatomical hemispherectomy. Postoperative function is usually better when the surgery is performed at a younger age because this maximizes neuroplasticity, and especially when a child after surgery has the appropriate rehabilitation in terms of physiotherapy, occupational therapy, they can do very well. And so the majority of children after a functional hemispherotomy do walk independently. We have children who've had functional hemispherotomies and they're running, jumping, playing soccer or tennis or keeping active. In terms of fine motor skills, that can be affected in the opposite arm. So if a child has a right-sided functional hemispherotomy, that can impair the fine motor function. So individual finger movements of the other side of their body. So in that particular case, the left hand. A visual field cut is expected after a hemispherotomy. In most children, the developmental trajectory remains stable, or it can even improve after a functional hemispherotomy. So that was anatomical hemispherectomy and functional hemispherotomy. I'll also talk about a focal resection or disconnection. And these are used in selected children with either that second pattern of involvement, unilateral heterogeneous involvement, or the third pattern we talked about, the focal involvement on MRI, in which their seizures are arising from a specific restricted portion of the brain. And the rationale for doing a focal resection or disconnection rather than a functional hemispherotomy is that it could potentially decrease the potential for postoperative neurological deficits. The specific neurological deficits that arise from a focal resection or disconnection depends on which lobes are being disconnected or removed. Often you'll hear about posterior resections or disconnections, which are motor sparing since they do not involve the frontal lobe, which is responsible for motor function, and only remove the posterior areas of the brain. It's possible that a child will have a focal resection or disconnection, and that does not have an impact on their motor or strength. Finally, I'll mention that there has been much literature about the effectiveness and safety of these surgical procedures in children with Sturge-Weber syndrome. And so here on this screen, I've listed some of those reports, which range from case reports to series of dozens of children who have Sturge-Weber syndrome who have undergone epilepsy surgery. This was a recent review paper that looked at the seizure outcomes in children with Sturge-Weber syndrome undergoing epilepsy surgery. And what they found was that almost 80% of children who underwent epilepsy surgery were seizure-free at their last follow-up. And their conclusion is that both hemispherectomies and focal surgeries achieve favorable and comparable seizure outcomes in appropriately selected children with Sturge-Weber syndrome. Dr. Pinto and I have also started looking at the surgical experience at Boston Children's Hospital in children with Sturge-Weber syndrome. There have been 17 children who have undergone surgeries at our center, and 7 of them had anatomical hemispherectomies, and these were done quite a few years ago. before 2007, 2008. More recently, we have had children who have undergone functional hemispherectomies, and we've also had children undergo focal resections and disconnections. And overall, they've done very well. The majority have not had any complications, and the vast majority, as you can see on this pie chart on the right, are seizure-free. And so in the navy here, we have the proportion of patients who are seizure-free. And in this lighter blue color, we have a patient who still has rare seizures, but certainly has had improvement after their surgery. And so the takeaway messages are that epilepsy surgery can be an effective and safe intervention for children with drug-resistant epilepsy, and to consider this and discuss this with your pediatric neurologist or epileptologist. So thank you very much, and I'd be happy to answer any questions.
Michelle, thank you for your talk. That was very informational. I appreciate that more than you know. Here's your chance, guys. Don't be shy.
Hi, Michelle. My daughter actually had a right hemispherectomy when she was 7 months old, and you pretty much just explained everything that was not explained to us. Her seizures were starting to cross over to her healthy hemisphere, so it was rather a quick decision we had to make. I've always been concerned about her visual field cut. That's never been fully explained to me, as far as how she sees. Could you maybe go in, like, explain a little bit of that?
Sure, definitely. I hope your daughter is doing well
She was
after the
doing
surgery.
wonderful. Yes, thank you.
Excellent. That's great to hear. And it sounds like she had the surgery pretty early on. And so that's great that from a developmental perspective and seizure perspective to hear that she's doing well. In terms of the visual field cut, has she been assessed by a ophthalmologist recently?
Yes, she's had one her whole life. She does have glaucoma, and she's had glaucoma surgery twice. Um, but I don't know, I guess it's so rare in Texas that it's just hard for them to really tell me, and she doesn't display a lot of she's adapted extremely well, so it's hard to ask her or to look at her and see, okay, well, do you have a deficiency or not?
Right.
So
Well, with a visual field cut, so as you can imagine, when you're looking out your visual field, there's the right side and the left side of your visual field. If a child has a right-sided hemispherectomy or hemispherotomy, then it would be the opposite side that could potentially be affected. So with a right-sided functional hemispherotomy, it would result in a left-sided field cut, and vice versa. With a left functional hemispherotomy, it would be expected to result in a right-sided visual field cut. Now, in terms of day-to-day, a child, especially if the visual field cut was established early on, for example, with an early surgery, they may actually adapt quite well. And so when they're walking or running day to day, you might not notice it, and it may be picked up, for example, on an ophthalmologist's careful visual field assessment. And so even if a child does have a visual field cut, it may not have as much of an impact day to day.
okay.
Where it may present a potential issue is when the child grows up and is looking at potentially driving.
Okay, yeah.
Depending on how complete the visual field cut is, that could affect their ability to drive. So if it's a complete field cut, They might not be able to get behind a wheel, but it depends a little bit on what their ophthalmological assessment shows at that time.
Okay, she's 6 right now, so right now my concern is reading, because you know how we read left to right, and I think the only time I've seen her display any kind of like, oh, I can't see well, was when she was getting assessed and they had her cover her right eye. She was very, very upset because she didn't like how it was looking, because she's had the right side disconnected, so the left eye is the one that's affected, right? Um, so that's the only indicator I've had, like, seen from her, that she does have some kind of visual field loss.
With a visual field loss, you know, it actually affects the so if we're talking about a left visual field cut, it actually affects the left half of the visual field in both eyes.
Oh,